Welcome from ASCO. I'm Everett Vokes. I'm president of the American Society for Clinical Oncology, and it's my honor and pleasure to greet you and to speak to you today about our work in ASCO and, of course, our partnership with the Indian Society of Medical and Pediatric Oncology. It's a real pleasure, and I greatly appreciate the invitation to speak to you. So a little bit on ASCO's background. We are the world's largest society for oncology professionals. Our mission is to conquer cancer through research, education, and promotion of the highest quality and equitable patient care. And our vision is, of course, a world where cancer is prevented or cured and survivors are healthy. And our core values are evidence, care, and impact. Of note, we have 45,000 members in 150 or so countries, and I know India is well represented and hopefully will be even better represented moving into the future. We do work with a lot of international organizations, and ASCO is thriving as a global organization, and we want to enhance that. And if we can have further connections with India in particular, we would welcome that. But here you see some, including Indian societies of collaboration, and you see at the very top the Indian Society of Medical and Pediatric Oncology. So equity became a major focus of ASCO. It's always been a focus. Equitable care is something that is the bottom requirement for cancer care. And it is something that ASCO has highlighted even further in the last year or so by adding it to our mission statement, which you see here: conquering cancer through research, education, and promotion of the highest quality and equitable patient care. And equity, every patient, every day, everywhere was ASCO's theme last year. And you see just how many aspects of our life and society and culture and family is affected by equity. And we just listed a number of them here, but clearly many of them are of vital importance to cancer care and listed here. And I don't want to read all of these, but you get an impression just of how important it is. And that's true for American society, and I'm sure it's true for Indian society. So moving forward, my theme for this year is advancing equitable cancer care through innovation. And the hope was to build on the theme of equity, because it is important, it continues to be important, but also coming out of COVID, and I realize we're not quite out of it yet, but the idea is that after you go, society, the world, through major crises, that very frequently coming out of that, there is a push to innovation because people recognize that some of the barriers that were put up before are no longer relevant. And that can be about how we interact with each other. It can be how we interact with our patients. And it can be how we take care, in some cases, remotely of patients. And so I want to give examples of how ASCO is thinking about this moving forward. So we want to innovate across boundaries and bring down the barriers to access, make care more equitable, convenient, and efficient for patients worldwide. We recognize that, of course, a lot of progress has been made in the last 50 years, but it's uneven in how it is accessible to patients worldwide, and deep-seated disparities remain across societies and also within societies. So here are some examples. First of all, bring down barriers across disciplines. ASCO has always been a big body of all specialties are included, but moving forward beyond the traditional medical specialties, be it surgery, radiation, medical oncology, pathology, there's also artificial intelligence. There is big data networks that are emerging. There's leading health information technology, precision diagnostics, and I think we can do better in how we conduct clinical trials and provide access to our patients. Here's an example of using health information technology. Cancer Link, you may have heard about, is largely American at this point, but not completely. It's driven by input of data from many private practices, and that can then be exploited for research. Here's an example on the right side where disruptions of US medical oncology care during early COVID was investigated. This was presented last year at ASCO, and showing how that access in decline early on in COVID, in particularly, affected Hispanic populations of patients. Of course, since then it has largely recovered, but still an important finding that COVID affected different components of society in different ways. We also want to use technology for education, and ASCO has started the new plenary series. Of course, we do have the annual meeting, and that will be live in person again this year in Chicago in June, but it will also be hybrid, so it can be accessed through the internet. But moving forward, we think we cannot just present information once a year. Important information comes out on a regular basis. And so we put together a team. ASCO staff is Dr. Jamie Van Roon, Lisa Greaves, and Lindsay Herr, with our volunteers. You know those names: George Sledge, Melissa Johnson, Tony Chereri, who on a monthly basis review ASCO, submitted abstracts, and we come to a plenary series where one or two abstracts of high clinical impact are presented once a month, and that's actually happening this week for ASCO, and it is like a plenary session, so a 10-minute presentation, a discussion, and then a question and answer period to give everybody a chance to answer their questions. So that's our new ASCO plenary series that is happening in addition to the annual meeting. We also want to bring down barriers across specialties and care settings, look how we can employ precision medicine, have innovative models for patient care, and we want to learn worldwide how that can happen. How can technology be utilized so that patients don't just have to come to an office, to the wait there, see a doctor, and then go home. And improve survivorship care and clinical trials, which I'll address a bit later in this talk. So here's using health information technology for quality. We have the Oncology Medical Home certification, and this too can be accessed internationally. It is predominantly American at this point, where ASCO provides a digital platform to allow for availability and access, to measure evidence-based medicine, to evaluate equitable and comprehensive team-based care, look at quality improvement, the way palliative and end-of-life care is administered, and of course, always chemotherapy safety and patient engagement. This has been updated and reformed, and hopefully will lead to further improvement in how oncologists can deliver medical care. Across geography, we are a global organization. We want to talk to global experts to spark new ideas and collaborations, to foster research, exchange ideas on cancer care delivery and prevention. We work on resource stratified guidelines, not the same rules apply to every clinical setting in every country the same way, and expand virtual platforms, such as I already mentioned, with the monthly meetings to deliver education and mentorship programs to oncologists worldwide. So some examples of global education and engagement. We have global webinars, we have training courses and symposia that improve practice. We want to collaborate with local leaders, members in oncology societies and governments, focusing on multidisciplinary care management, palliative care, clinical trials, and cancer control. And you see here examples of how it used to happen in person, and we hope to resume that at some point in the near future, but also how it can happen currently and is in fact happening right now in terms of doing virtual education. We have a international workforce. There is regional councils. There is an Asia Pacific Regional Council you see here when it met last in person with Dr. Burris, who was president at the time, and Jamie Van Roon, and some of our international members from that council. There is also a Latin American council and others that will be created moving forward. The breakthrough meetings, and this has happened up to now only once in Yokohama in 2019. It since has needed to be postponed, but you can see, looking at some of the future in oncology, drugging the undruggable, the microbiome, innovative trial design, novel therapeutics, multi-omic technology, artificial intelligence, and then using telemedicine, where we want to learn from one another, everybody, how we can better work with our patients without making them come through traffic into a parking garage and a waiting room where, you know, at this point even, they could be exposed to bugs such as COVID unnecessarily. And this is, of course, internationally organized. It involves some of our sister societies as listed here. We also want to have further best practices for global sharing. There is the JCO Global Oncology. This is an online journal that focuses in particular on global oncology and global care, and we do support through Conquer Cancer global oncology young investigators, and investigators are eligible for these awards on a worldwide basis. Some of the examples of what we have published in global oncology or is ongoing in global oncology, you see here an assessment of adult women with ovarian masses and the ASCO resource stratified guidelines for how to approach that. And another example were quality measures in Uganda that were published by ASCO member Dr. Jackson Oram. So what are resource stratified guidelines? They take into account evidence-based, economically feasible, culturally appropriate factors. They're graduated and region-specific. Cost and complexity of healthcare delivery is taken into account, and we aid in prioritizing resources and strategizing equitable phased implementation of cancer services. And this is not top-down from ASCO. It is in collaboration with the oncologists and professionals involved in those regions to make sure it is appropriate. So here you have some of the guidelines that have already been published: cervical cancer, palliative care, colorectal cancer, ovarian cancer, and metastatic breast cancer. And the committee co-chairs here are listed with Drs. Al-Shakun and Graylow. So looking forward, we think that across geography, using the way we can now interact and are interacting right now, we can really interact at all times. Now there are some time and regional sensitivities, and use this technology to have virtual platforms to deliver education and mentorship to oncologists worldwide. Dr. Julie Graylow, I want to just introduce here briefly. She joined ASCO as CMO a year ago, has a very deep background in medical oncology as Director of Breast Medical Oncology at the Fred Hutch in Seattle, and a longtime ASCO volunteer, but predominantly really a leader in global oncology and a terrific partner to me during this year of my presidency. So I mentioned clinical trials, and clinical trials are, of course, what moves our field forward. based on basic discoveries that are made before. There are very high standards for how we conduct them, and we want to maintain those. But we also need to look at access to those, who is excluded, who can be included. So in the United States, we have now a collaboration between ASCO and the Association of Community Cancer Centers to try and have more equitable participation in clinical trials. But we've also learned during the pandemic that we can further facilitate participation in trials. So there was a panel of investigators and leaders in oncology put together. This was early during COVID with Skip Burrs as leader. Nate Pennell was the first author of this publication that resulted from that. And the idea was to think about the unprecedented and unexpected challenges that all of a sudden hit us, and to help improve access to equitable and affordable care during COVID and also after COVID. And the task force was charged to deliver 5 cancer care goals, delivery goals, and 5 cancer clinical research goals. And you see some of that here from this paper. In particular, for the highlights mentioned here, it is important to improve patient access to cancer care via telemedicine, and that should be maintained after COVID is over. Treatment modifications, so are treatment interruptions appropriate at times? What could be done at home in terms of home infusions? Early on, what about protective personal gear that was not always available, masks, gowns, and of course, communication with local health departments. Specifically for trials, virtual consenting. So does a patient really have to come in to sign a document, or can we do that remotely? Can trials be better integrated into routine care? Because frequently, the best trials are actually seamlessly integrated into the routine care we want to give. Streamline regulatory requirements, that's relevant in the United States. I'm sure it's relevant worldwide. Retain that telemedicine access so that some visits, at least for patients, can be done without a whole family frequently having to put their other activities at rest and come to work, to come to a hospital or clinic. Increase grants to underserved populations. Affordable insurance is important. In the United States, Medicaid access. And of course, the stress that COVID put on our providers and what we call wellness to try and make sure that our providers can stay comfortable with their roles and still have a personal life that is fulfilling. So moving to the future, this is from a paper by Dr. Flaherty and colleagues in Cancer Discovery. You see here on the left, this is how it used to be. There's a hospital, there's in the hospital, the chemotherapy suite, the technology to do all the trials. And patients come with their information, they come to get the pills and to be seen there. In the future, we think the patient should be in the middle. Patients can go locally to get their treatment or evaluation. They can use telehealth to sign for consents. Pills can be delivered or sent by mail, and infusions can be given frequently closer to home or even in the home with appropriate supervision and teaching, so that patients don't have to necessarily come and spend a lot of time in hospitals and care facilities. So that is my last slide. I want to thank you for your attention. And if there's time for discussion and questions, I'll be very happy to try my best to answer those. So thank you very much. And on behalf of ASCO, thank you very much for the invitation to participate in your meeting today.